Okay, Michel is with us. So let me do a quick introduction so we don't carry it for too long. So I think everybody knows Professor Michel Haïssaguerre. Michel is a professor of medicine at the University of Bordeaux, and also the founder and director of the LIRYC Institute, which combines care for cardiac arrhythmias with really extensive investigation and research of arrhythmia mechanisms. Michel is for and foremost a distinguished clinician. He takes care of people with arrhythmias and has introduced to the field and studied and perfected many strategies for interventional EP. He's also a remarkable clinician scientist, in the sense that he really established many of the mechanisms of arrhythmias as connected to treatment and related to treatment, notably the source of atrial fibrillation in the pulmonary vein orifices, which led to the pulmonary vein isolation during catheter ablation, the role of Purkinje as initiators and triggering arrhythmias, the important role of early repolarization in life-endangering arrhythmias, and many more. Michel has received numerous awards and prizes. I cannot list them all, but not the least of them is the Le Foulon de Lalande Grand Prix Scientifique, which is really a very prestigious award. So today, Michel will explain to us everything about unexplained sudden cardiac death. And we'll keep, please, your questions to the end. Send them to me or to everyone, actually. Send your questions to everyone in the chat box. I will read those questions at the end after Michel's presentation, and then we'll hear his responses and explanations. So that will be the order of things. And please keep yourself muted so we don't interrupt with the presentation. Thank you, Michel, for joining us. It's a real honor and a real pleasure to have you.
Thank you, Ron, for this invitation. Good morning, ladies and gentlemen. It is a pleasure to present this topic with a prestigious group of Yoram Rudy and his colleague on cardiac bioelectricity and arrhythmia center seminar. My talk is about unexplained sudden cardiac death, which is the main cause of sudden death in young adults below 35 years. About 30% of this population in many different countries are stricken by unexplained sudden cardiac death. Otherwise, ischemic heart disease and cardiomyopathy are the main cause in older population. The greatest challenge in the last guidelines for management of patients with ventricular arrhythmia and prevention of sudden cardiac death is to identify the high-risk subgroup at risk of sudden cardiac arrest, particularly structural heart disease with a mild altered ejection fraction, or the vast population of normal subjects with no identified disease at risk of death as their first cardiac event. Why we have to be fascinated by VF in apparently normal heart? VF is consistently the arrhythmia responsible for sudden death in patients without structural heart disease. VF has more discrete substrate than VT on imaging or normal left ventricular function, and is less predictable than patient with VT. Idiopathic is a word that scientists and cardiologists dislike. And idiopathic VF, I think, in contrast to multivariable mechanism of sudden cardiac death in apparently with abnormal heart, may have elementary, a monofactorial mechanism that a careful phenotyping can disclose, and it may help to decipher the different mechanisms at play in the role of sudden cardiac death. The method that can help us for novel clinical insight as first, in the clinical point of view, a detailed phenotyping. And I think we have to use a systematic screening, and that a single test that we have not performed in this screening can provide the only significant result for elucidating an unexplained sudden cardiac death, and neglecting one of the tests can make you miss an essential clue. We will see the role of mapping during ongoing VF with non-invasive ECGI, and we also will develop the role of detailed electrogram, endocardial, and epicardial mapping during sinus rhythm to discover some subtle and infraclinical cause of unexplained sudden cardiac death. Finally, we are lucky to have in Bordeaux the capability to work on ex vivo human heart by donation. This heart can be viable for 6 to 8 hours, and we can do optical mapping, microelectrode, high field and power MRI, histology, molecular, and we have a gold mine of information from this ex vivo human heart. This is the mapping during ongoing VF using the ECGI system. The ECGI system is very useful to map during arrhythmia. However, we found the system to be less efficient in mapping in sinus rhythm, and we have published an article in which there was a significant discrepancy in sinus rhythm between the data from the VEST and the data from invasive mapping. However, concerning this article by Dr. Duchateau, we have not well followed the editing process, and unfortunately, I think, and I apologize to Yoram, the wording was too strong and not sufficiently weighted. Nevertheless, we use the ECGI mainly now to map the initial sequence of human VF. This is the system of use during this window of ventricular fibrillation. You can see easily the organized phase of VF and the disorganized phase of VF. When we map the initial sequence of organized VF, we have this type of mapping. Right ventricle, inferior view, left ventricle for 5 seconds. And we have 2 clusters of re-entry here and here. And during this initial phase, we have nice electrograms. And if we look at these 6 reconstructed potential around the re-entry area, you can easily follow that we have a sequential activation, and probably this re-entry is true. Now, when we look disorganized phase of VF, the window is from 15 to 20 seconds. We have a disorganized activity, and it's difficult to map the electrograms at this time. I mean, it's difficult to prove by the reconstruct electrograms that the re-entry can be confirmed. This is a case of Brugada syndrome. And when we map the initial second of VF from 0 to 4 seconds, you see main activity, focal activity here, or re-entry here, are in the right ventricle. This is this phase on the 12-lead ECG here. And when we map during the 4 to 6 seconds, you see all this driver activity moving to the interventricular region, say the septal projection. And 2 seconds later, everything is in the left ventricle. And this is very common. The initial organized phase of VF provide more specific information during the initial second of organized VF than later, where most of the activity are dominantly located in the left ventricle. This is a case, 2 cases of ischemic heart disease, is where mapping during VF show the most spectacular clustered reentry in the apex and close to the septum of the left ventricle in this patient, and in the inferior left ventricle in another patient. There is a second point. You see 2 very special cases of VF. This young man has hypertrophic cardiomyopathy. You see the initial second of induced VF. And this is another man with dilated cardiomyopathy, 62 years. And you see a non-specific mapping of driver during VF. We have a main spot in the inferior left ventricle at the region where we have the papillary muscle. And in this case, we have used a catheter located in the Purkinje, left Purkinje in the left ventricle. And you will see the mapping, an endocardial mapping of the Purkinje for these 2 episodes in this slide. This is the young man with hypertrophic cardiomyopathy. You can follow from the distal Purkinje to the proximal fascicle the mapping in sinus rhythm. And during all the initial beat of VF, we have 1, 2, 3, 4, 5, 6, 7, and 8 or 9 Purkinje at the initial beat of VF. In this man with dilated cardiomyopathy, we have also many of initial ventricular waveform that are associated with Purkinje activity. And after disorganization of VF, we lose this Purkinje activity. In these 2 cases, we have ablated only the Purkinje, and we have not ablated the myocardial substrate, and we have a successful outcome. There is a significant subgroup of patients with structural heart disease who have repetitive Purkinje activity, spontaneous or induced during programmed stimulation. That is a very interesting subset, as it is more simple to ablate the Purkinje than to ablate the abnormal myocardium. This is a schematic view of the initial activity at the onset of human VF. We have a trigger, most of the time from the Purkinje. This is a spontaneous initiation of VF in a patient with post-myocardial infarction. And for a window of several seconds, we have some activity driver from close to the structural substrate or from the Purkinje close to the structural substrate. And after 4 or 5 seconds, we have completely disseminated activity. Now we will see more in detail the case of unexplained sudden cardiac death. Why we should be fascinated by ventricular fibrillation in normal heart? VF is consistently the arrhythmia responsible for sudden death in patients without structural heart disease. VF has more discrete substrate than VT and is therefore less predictable. Idiopathic is a word that scientists and cardiologists hate, and idiopathic VF, in contrast to multivariable mechanism of structural heart disease, may have an elementary mechanism that a careful phenotyping can disclose, a bit like a Rosetta Stone. About half of cardiac mortality is due to sudden cardiac death, ischemic heart disease, and more recently, more cases of cardiomyopathy. We will focus today on young adults of less than 35 years, in whom the most common finding is unexplained sudden cardiac death. We will remind you that epidemiological markers provide probability for population, but not risk stratification of individual. The greatest challenge is to predict the risk of sudden death in two small high-risk groups: heart disease with mild altered ejection fraction and no identified heart disease within the large general population happening here, where sudden cardiac death will be the first cardiac event. The group of VF in apparently normal heart is about 10 to 15% of the population of sudden cardiac death. And VF is here the type of arrhythmia leading to death, compared with heart disease, where often cardiac death is due to VT degenerating in VF. We have 5 main causes of VF in apparently normal heart: Brugada, G-wave, long or short QT, catecholaminergic VT, and idiopathic VF. This is, in this slide, the incidence of unexplained sudden cardiac death in young population. What is striking in this study in Denmark or in Sweden is in people less than 35 years, the first cause of unexplained sudden cardiac death is constitute 31% of the population here. In Sweden, you have the same thing, and the same value is found in this study in an athlete in USA, in US military, or here in UK. Unexplained sudden cardiac death is the first diagnosis at autopsy in young victims. And this is the systematic screening protocol we have to perform to diagnose unexplained sudden cardiac death or idiopathic VF. First, we have to eliminate structural heart disease. Second, we have to search for ectopy, particularly in intensive care unit where less attention is given to PVC. We have a clinical research nurses that take care of all this screening, including the different drug testing. And detail are provided in this review in the Journal of American College of Cardiology, EP. In fact, the main advancement we have in this pathology came for performing discrete myocardial abnormality using endo and epicardial mapping during electrophysiologic study, or using mapping of the Purkinje system to find some microstructural abnormality. The role of genetic testing will grow in diagnostic, in prognostic, or in therapy, but the main issue of genetic testing that we have a myriad of variants of unknown significance with some precise functional significance. This is, in this topic, I will talk more about the phenotyping and the role of deep phenotyping. You can see here that an abnormal response to one of the tests we perform in the screening protocol can provide the only abnormality detected by the screening protocol. If you miss this test, here it was isoproteinol testing, you can miss the diagnosis of or the explanation for syncope or sudden death. This lady is 56 years. She had unexplained syncope during horse riding, and after weeks of no diagnosis, we have performed this test that immediately performs the response by inducing ventricular fibrillation. We didn't find any genetic abnormality. She is perfectly well under nadolol since 20 years. Now we will see some cases. This case 1 is a woman, 35 years, family history of sudden death. She had syncope, particularly when she was swimming, and you all see the diagnosis of long QT. This is not a frequent diagnosis. Syncope or sudden death can be the first presentation of congenital long QT, but most of these patients are asymptomatic, and the diagnosis is done in the screening of a family with a victim of sudden cardiac death. You can see on expert consensus recommendation what are the diagnoses, what is the score we can have to predict the risk of a long QT and the need for beta blocker or for more aggressive treatment. Approximately 20 to 25% of patients with long QT may have a normal range QTc, even if we have confirmed the diagnosis by a gene mutation. We have to perform some dynamic maneuvers, like a standing position during the ECG, or after some effort. You can see in this patient QT which looks normal at the baseline, and after some effort it becomes longer, allowing the diagnosis of long QT. The role of drug testing or family screening is particularly important to diagnose the long QT syndrome. In this patient, 45 years, a mother, we could not have any diagnosis for several weeks of a full screening. She had an unexplained VF, and you can see the QT/QTc looks normal. And it's only after a screening of his son, 17 years, that we have the diagnosis. This was isoproterenol testing. This is 2 minutes of the perfusion of isoproterenol. Look at the QT here in V2, V3, and after 2 minutes and 30 seconds, we had abrupt changes in the position and the morphology of the QT, long QT, and we had here the diagnosis of alternance. We make the diagnosis of long QT in the son, and a few weeks later, we had a long QT gene mutation, both in the son and the mother. We have different type of long QT, at least 15, but 90% of long QT are the form 1, 2, or 3. And notably, we have some distinct phenotype like a long QT3, which is a mutation in the SCN5A sodium mutation, as a very specific phenotype, more symptoms during the rest than long QT1 and 2, where we have during the stress or emotion or effort, we have the symptoms. The long QT7 with KCNG2 has also some bidirectional arrhythmia, which is very specific. Different therapy of long QT, you can see that on the different review recently published on that. There is a list of forbidden medication, and beta blocker as the main treatment for the long QT1 and 2 particularly, and other options are possible depending on the context and the failure of the different medication. This is the case 2, a man, 22 years, 2 syncope while walking, and at first sight, you can recognize a short QT, and the short QT is diagnosed in the presence of a short QTc less than 330 milliseconds. And this is a very rare and often family history of sudden death. And we have some mutation in the sodium channel or in the calcium channel that is known. This is a very typical case of catecholaminergic polymorphic VT. This is a diagnosis we made in 1977 because of repeated syncope during effort, and this man has died while on propranolol 1 year later. The diagnostic of CPVT is first clinical, a child, syncope during physical or emotional test, and gene mutation is found in the ryanodine receptor or in calciquestrine in 75% of these patients. Now we have more frequent disease, Brugada syndrome and J-wave syndrome. The diagnosis of Brugada syndrome, the prevalence is here, is based solely on a specific but labil pattern in the ECG defined by a 0.2 millivolt covered type ST segment elevation. Now, the last consensus indicates that one precordial lead is sufficient to make the diagnosis. And in case of non-diagnostic ECG, we have to perform some pharmacologic testing. The main clinical issue of this syndrome is to define what is the risk of sudden cardiac death, particularly in asymptomatic patients. In the big registry of hundreds of cases of Brugada, only 1/3 of the symptoms of patients have symptoms and 2/3 are asymptomatic. It's a bit like a situation with a long QT syndrome. We can do high positioning of V1, V2, or we use in Europe Ajmalin to make a testing and prove type 1 Brugada syndrome. I know that in US, procainamide is used, and this is less sensitive than Ajmalin or pulsicynid to make the diagnosis of Brugada syndrome. The risk factor of sudden cardiac death in this syndrome is syncope, like in long QT. It's a man, a type 1 ECG, and it seems that repolarization abnormality, J-wave syndrome in the inferior leads, or QT dispersion are in recent studies particularly associated with higher risk of sudden death. What is undetermined is a family history, sodium channel mutation, or the role of programmed stimulation in allowing a better risk stratification. I would like to emphasize that the Brugada syndrome is mainly a cardiomyopathy, mainly affecting right ventricular epicardium, as shown in different studies, and the repolarization that makes the diagnosis of long QT is a secondary phenomenon. It's not the main phenomenon. You can see here some electrograms in the epicardium made by Professor Nademani. You can see this is the right ventricle, this is in the left ventricle. These electrograms are exactly the same than those defining cardiomyopathy, dilated or hypertrophic, or post-myocardial infarction. The management of Brugada syndrome is indicated in different reviews. One of the discussion is about ICD. We have some therapy like catheter ablation of the epicardial substrate or as quinidine that is available. And all the patients, even asymptomatic, should have a list of forbidden drugs that you can access on the internet. Now, we will move to two different important diseases, J-wave syndrome and idiopathic VF, where we have a novel insight. I will just emphasize the two main techniques that have helped us to advance in the physiopathology knowledge of this affection. The high-density endo and epicardial mapping in survivor of this disease has allowed to find some microstructural alteration. We also use some non-invasive mapping during VF to see where are the site of rotational activity during VF, the site of the rotor, and that allowed to point to this location to map with a pentarray and found what is special at the site of rotor. And in Bordeaux, we have the opportunity to work on ex vivo human heart in the LIRYC Institute. We have the access to human heart that are available for 6 or 8 hours, and we can do very complex mapping, electrophysiologic mapping. We can do MRI high 9.4 Tesla, some histological, and we can learn a lot of information from this experiment in human ex vivo heart. The early repolarization has an unclear prevalence. Most of the patients are men, and is ST elevation or J-wave syndrome in the inferior leads, 2-3 VF, and sometimes in the lateral leads. This is 2 ECG with the J-wave syndrome in the inferior leads, and with a group of Nademani in Bangkok, with a group of Nogami, Professor Nogami in Tsukuba, and in Bordeaux, we have worked on 52 cases where a complete endo and epicardial map has been performed. What we have done is we have mapped only the J-wave part. We didn't look this part or this part, but we concentrate all the mapping on this part to see what is the activity at this time. And in fact, what is happening during the J-wave syndrome can be repolarization, like you can see here, or can be depolarization, like you can see here. And this is a man of 23 years old. He has a huge J-wave syndrome in inferior and lateral leads. And when we map extensively endo and EP, you can see here that depolarization stops at the end of the QRS here. And what is happening during the J-wave is only repolarization syndrome. And when you see here on non-invasive mapping, all the activity shown as a hump at the end of the QRS is occupy all the apex and a part of inferior left ventricle. It is a repolarization abnormality. This is a true early repolarization. Quinidine can be effective, and Purkinje cells are frequent triggers. And what is probably the most specific sign is the variability of the end of the QRS with the pause. When there is a long bradycardia cycle like here, you see the amplification of the last J-wave, and this is probably the most typical pattern of early repolarization. Now, what we observe by endo and EP mapping, that we may have the end of the QRS J-wave that can be depolarization. And most of the time, it happens at the time of terminal activation in sinus rhythm. We can find them in the inferior part of the right ventricle or of the left ventricle. And in fact, this J-wave here is like the reverse delta wave, is a post-excitation, like delta wave is a pre-excitation. It's a depolarization abnormality. It's often associated with Brugada syndrome, and ablation is effective. So in front of a J-wave phenotype, you have to decide if it's depolarization or repolarization by doing dynamic maneuvers or by doing endo or epicardial mapping. This is one case. This man is 19 years old, and he had VF during the night, and we have just a ST elevation in the inferior leads that looks to be something benign. And when we map this young man, we had abnormality of voltage in the inferior right ventricle, like you can see here, and with this type of long fractionated potential here. This is the 2 patients who died, and we can get some the heart. This is a typical case of J-wave syndrome. And in this lady of 65 years, all the J-wave, by doing optical mapping, was a delayed activation at the basal part of the left ventricle. We had a lot of collagen content here. This was the proof that it was a case of delayed depolarization. And this is a case I showed you before, with a dynamic change in the early repolarization. This lady had a storm of VF we cannot control. She finally had a transplantation. And this is a heart we had post-transplantation, where we had no abnormality of depolarization, but just a part of short APD in a part of the left ventricle, and with microelectrode, we can prove that we have possibly ITO amplification of activity. This is have been presented in the HRS before. It is clear that depending on if you have depolarization of abnormality or repolarization abnormality, you will have distinct treatment, distinct risk stratification, and a different interpretation of the genetic result. Now, we will focus on idiopathic ventricular fibrillation defined by no phenotype. We have mapped 51 patients with idiopathic VF diagnosed with the negativity of all the screening we showed before, and we have excluded also abnormal J-wave or structural heart disease. What we found is a spectrum again of substrate that underlie idiopathic VF in a human. This has been published 2 years ago. In most of the patients with idiopathic VF, you can appreciate here the normality of this ECG in this lady. We found in most of these patients, in close to 70% of them, we found some abnormal depolarization in one part of the heart, often it's a small area, which is mainly epicardial. It can be anywhere. It can be epicardial right ventricle, epicardial left ventricle. This is another example where we have a 34-year-old man who had VF during sport, and everything was negative. And when we did mapping in the right ventricle, there was nothing. But in this part of inferior left ventricle, in this part of lateral left ventricle, you can appreciate abnormal electrograms. That is exactly what you find in localized cardiomyopathy or post-myocardial infarction. In both this case and the previous one, we had late depolarization area, which was the mechanism of sudden cardiac death. And without invasive endo or epicardial mapping, you cannot make the diagnosis. 2 other cases, you see a perfect normally ECG in this young man, 23 years. In the epicardial inferior right ventricle, we had an island of abnormal potential with 0.12 millivolt of amplitude. And in this patient, we had a huge abnormality affecting all the epicardial anterior right ventricle in this man of 47 years. If you don't look for that, you will miss it. There is a second category of idiopathic VF where Purkinje abnormal activity can be found, and this represents probably about 10% of idiopathic VF. This patient, this lady had sudden death, and we have a short couple narrow QRS here, this man or this man, and all these cases are ectopy coming from the Purkinje activation. Idiopathic VF can also be without any spontaneous manifestation. We have published these 2 cases where everything was negative. We cannot evidence some ectopy, but when we do pacing directly from the left posterior fascicle, we can create long delay from the spike to the Purkinje, and we can induce polymorphic VT. In that case, we can see clearly the Purkinje spike along the polymorphic VT. And what is interesting is the cycle of the Purkinje interval is shorter than activation in the local ventricular muscle, indicating that the Purkinje was driving the myocardial activation. And in these 2 patients, we had induction of VF, which was preceded by the polymorphic VT induced inside the distal Purkinje system. We have 2 patterns of Purkinje activation in idiopathic VF. Ectopy, probably some calcium handling abnormality, or inducible polymorphic VT, which are associated probably with sodium conduction or structural gene abnormality. This is again an ex vivo human case. We had the opportunity to map. This young man was playing a sport, and when he had some rest after the game, he had sudden death. He died after 2 weeks of brain damage, and the family asked us to map and try to explain what happened to their son. This is a heart. There is no fat tissue on the external part of the heart, which looks normal. And that, in fact, when we start optical mapping of this heart, we had the surprise to see that we had abnormal isochrone in the epicardial part of the right ventricle. This is normal isochrone, where you see a smooth change of propagation here. And in the case of this Pierre case, we had some abnormality close to the RVOT here. That is something like a Brugada LIRYC. It was only on the epicardial part and not on the endocardial part. All the repolarization on optical mapping was normal, and we can induce some re-entry in this epicardial part of the heart just by single extra stimulation. Donc, we have the proof here that a small area of abnormal propagation can be the cause of sudden cardiac death. This is a simplified pathophysiologic classification of VF with normal heart. We have abnormality of conduction in Brugada syndrome, in inferolateral G wave, or this subgroup of idiopathic VF, 70% of idiopathic VF who had localized conduction abnormality. All these diseases are very similar, affecting a part of conduction in a part of the heart. We have a group of repolarization abnormality, long QT, short QT, or early repolarization G wave, where the heart is structurally normal, but the ionic distribution during repolarization is heterogeneous. And we have a group of abnormal excitation, IVF induced from Purkinje triggers, catecholaminergic polymorphic VT, or accidental excitation. And in fact, we see that the precise phenotyping can improve and will improve the genetic screening and interpretation. If you look at the G wave without differentiating if it's abnormal of conduction of abnormality of repolarization, you cannot properly interpret the genetic variant of unknown significance. And in addition, this classification in physiopathology group is very helpful to have a distinct mode of therapy. All these diseases here have the same electrogram diagnosis, and they have the same ablation technique as a treatment. When we look at this abnormality of repolarization here, it looks like to be an electrical dysfunction amenable to drug therapy. When we look at the cause of idiopathic VF or normal heart and VF due to Purkinje excitation or accidental, prevention and ablation of abnormal excitation will be the treatment. If you consider sudden cardiac death from a genetic or clinical point of view, it's very heterogeneous. We have multiple, probably, potential pathology. If you look now from the EP standpoint, the final impact will manifest as 3 dominant mechanisms: abnormal repolarization, most of them, abnormal repolarization or excitation in less of them. And we have unexplained case of sudden cardiac death in only 10% if you do all the full screening concerning this disease. In conclusion, deep phenotyping using high density mapping in sinus rhythm or in VF can elucidate a majority of VF with normal heart. There is an emerging group of patients with a subclinical microstructural alteration associated with this pathology. Purkinje activity plays a significant role in triggering and maintaining VF. Pathophysiological classification has significant implication for therapy and for genetic interpretation. I thank you for your attention.
So one question that comes to mind when you talk about a very limited mass of tissue that is responsible for VF, do you think there is a need for a critical mass? Do you think that it has to be larger than a certain minimum?
I don't know exactly about the critical mass. I know there were some experimental studies 20 years ago where they had dogs in which you cannot induce any VF. And they put some light hitting a bit the tissue,
Yes.
and increase the size of the light. And after 1 or 2 centimeters square, which is minimum, they can induce VF. And they increase the size, and there was an increase in the inducibility of VF until a plateau.
Yeah.
So, but 1 to 2 centimeters square is maybe is not so minimal. I don't know. But what is striking is we have patient who looks perfectly normal. Everything is normal, MRI, and this spot is enough to induce the initial reentry, then create a sustained VF.
Yeah.
This is a
bit interesting because we early on did some studies with ECGI on dog with warming and cooling of the myocardial, the epicardial surface. And when we had adjacent regions of deep cooling and increased temperature right next to it, fibrillation was spontaneous in the dog. So high, very, very steep dispersion of regularization, in that case, seemed to be an important player. So
there should be probably some specific architecture within the 1 to 2 centimeters square that is probably optimal to initiate the initial reentry.
Yeah.
Some topologic features.
Okay, the other question quickly is about the Purkinje. So Purkinje cells are more arrhythmogenic than myocytes. This is because, number one, they operate at a much higher calcium concentration. And the second thing is electrophysiological profile in terms of ion channels is different. They have higher IF and lower IK1, which causes less stability of the rest potential. So they're easier to induce delayed after depolarization. It seems that calcium plays an essential role in this mechanism. And the question is, do beta blockers help to prevent those triggers from Purkinje muscles? Do you have any experience with that? Do you know if beta blockers help?
What we have seen, and it has been confirmed by Sami Viskin, maybe the quinidine can work well, and the beta blocker work well in case where the firing from the cells are helped by catecholamine infusion. I mean, when is the mechanism, the calcium mechanism is related or dependent of catecholamine, beta blocker will work.
Yes.
Otherwise, quinidine, at least in clinics, works well.
Yeah, it's a question.
Yeah.
Good question.
Interesting is we have seen 7 or 8 patients with cardiomyopathy or hypertrophic or dilated. They have no ectopic from the Purkinje, but when pace, and we have a catheter recording the Purkinje in the left side, we see the initial 15-20 beat. Each beat is preceded by the Purkinje. I mean, if you don't have the catheter, you see VF, you will see electrogram fractionation, you understand losing. Now, if you have a catheter at the right place, you see the activity is really probably driving the myocardium. And after 20 or 30 beats, everything is dissociate.
I see.
We have a way to maybe to improve the condition of the patient, and it's a relatively easy way. And this has not been seen. It has been published that late VF can be associated with Purkinje, but not the very initial bit. Donc, maybe the mechanism may be different. It's probably something turning in the distal Purkinje, like Omer Behrenfeld and Halife have published.
The re-entry.
Yeah.
Okay, let me continue because there are other people who have questions. So Mathis Kloetmans from Maastricht is asking a question. Thanks for the very insightful presentation. You show the importance of deep phenotyping, drug provocation, EP study, imaging. You also show the use for ECGI for understanding VF mechanisms. My question is, do you foresee a role for ECGI for deep phenotyping, for risk stratification, for idiopathic VF, prevent, i.e. without actually inducing VF?
Yeah, it's a good question, Mathis. We have used ECGI to map in sinus rhythm, and we have been disappointed. I mean, it works well. We have to map some relatively big activity like focal with a spreading like that, or a big re-entry like rotor. But when we have a sinus rhythm with 2 or 3 different Purkinje exits, the current system from ECGI is a bit confused. I mean, there is something in the algorithm that we have mentioned to Medtronic at the time. There was something wrong here. So maybe we have to improve the inverse problems, and of course it will be an ideal system. But the current system in the commercial setup of Medtronic is not adequate. We can really, in fact, even in early repo, we see this very abrupt change in action potential. It's not exact. It's not exactly the same.
Well, I should interject in defense of ECGI.
No,
I must say that we get very good reconstructions in sinus rhythm also.
No,
our own in-house system. So, you know, we're getting
maybe you're right. Maybe the old system is better.
The older, the better. But no, we're getting very good reconstructions of activation during sinus rhythm, and definitely repolarization. I have no doubts about it. So yeah,
I'm not so sure.
The commercial system should be perfected and improved, but the principle, the principle have been proven, and now the details of the actual commercial system could be improved. It's a good system, but it could be tweaked to be even better. So
Yoram, you have to finish the job.
Yeah. Okay, next. Sasha Panfilov. Fantastic results. I wonder, do you see maybe fibrosis or other structural abnormalities on high-resolution MRI scans in areas of fractionation?
Yeah. Look, what we have observed when we have a small area of local abnormality on electrograms, we have, using the MRI 9.4 Tesla, we can see something abnormal. But this is only in experimental condition. But when we look at very special sequencing of MRI in clinics condition, it doesn't help. It's really invisible to MRI. But, sorry. Yeah. Donc probably high resolution MRI can help one day on that. There is no doubt that most of these local abnormality of electrograms are due to fibrosis or fatty tissue or inflammatory tissue. There is something where conduction is tortuous.
I see. Okay, next. We have a question from Eduardo Sternik, my friend from Brazil.
Parlez peut-être.
Okay, are you with us? Yeah. So the next question is from Eduardo Sternik, who is a friend of mine from Brazil.
Yeah.
I've met him in Brazil. I've seen some patients who survived CPR from VF, and we have found in 1/3 a small area with LGE in CMR. In your view, with current CMR imaging, using 1.5 to 3 Tesla has enough power to diagnose most patients with depolarization abnormalities? Do EP mapping endoepi has a diagnostic screening
Role.
as a diagnostic screening role even in negative CMR?
Oh yeah, yeah. What we call idiopathic VF is by definition a normal MRI, but we have not many, but we have of course a patient initially considered as idiopathic VF. We do MRI 1.5. We find an abnormality on LG late gadolinium enhancement. But what we are talking is this patient negative on MRI, and the diagnosis is made only by electrophysiological criteria. So there is two level of resolution we need. And maybe the next step will be 9.4 Tesla, and we will see them. We can also imagine we work on ultra-fast echocardiography with thousands of pictures per second, and maybe also it can help to find some abnormality, particularly on the anterior wall. Now, electricity is more sensitive to find that than MRI, at least in this population group.
Okay. Derek Dostal, interesting talk. What are the clinical implications of ablation of portions of the Purkinje system? Do patients end up with prolonged QRS or abnormal activation sequence?
Yeah, we are burning the distal part of the Purkinje, and there is a little or negligible change in the QRS. And specifically, we ablate where the Purkinje muscle is less than 15 or less than 10 milliseconds. So the impact, we burn the distal arborization, and we have little impact or no impact on the QRS. It's a very smart ablation. Huh?
Yeah.
So simple, compared with a myocardial scar for VT.
Okay. Next is Peter McFarlane, another friend from Glasgow, Scotland.
Yeah, Peter.
You showed end QRS notching frequently. Should end QRS slurring be removed from the criteria for early repolarization?
Yeah, okay, Peter. Yeah, it's in the eye of the beholder, right? But it's true. The same phenotype can express two different things. And maybe we have to call J-wave something that is late depot and early repo, but we need to know the diagnosis. But the external phenotype on the ECG is sometimes the same thing. It's not so easy to differentiate.
Okay, so we still keep the slur. We still keep the slur in early repolarization criteria, yes?
Sorry?
You still keep the slur in early repolarization criteria?
Yeah, I would say that at the baseline, the J-wave can be the same, But what is probably more specific of early repo is a dynamic change with cycle length.
Okay.
When we see accentuation of J wave when it's slow and vice versa when it's fast, this is clearly something that is repolarization related.
Okay, thank you.
Okay, next, Shiv Kumar. Shiv has only a statement to make, and he's saying, excellent presentation. Then Gil Bab from
Thank you.
Montreal. Thanks for a very stimulating talk. You showed several examples where you found patients with abnormalities that could explain VF. How prevalent are these types of abnormalities in the general population?
Yeah.
The prevalence, let me scroll down, does the prevalence of these abnormalities correspond to sudden cardiac death incidence in the population?
Yeah, it's a crucial question. The issue is, given the diagnosis has to be made invasively, maybe one day by ECGI, the issue is very hard to get a normal population. We have an ethical issue, and we have submit at the ethics committee one protocol to do that in patient on surgery, and we have been rejected. Look, we don't have, we have only 15 patients with invasive mapping because they were considered to have a normal heart. So it's very hard to go more deeply in this, the prevalence of this abnormality in normal population. We know that using MRI, some of the patients have late enhancement. It's 1, 2, or 3%. This is an important question.
Thanks.
Next one is from Natalia Troyanova. Thank you, Michel, for the very insightful presentation. A recent study investigated the role of tissue heterogeneity on CT for identifying areas of late potentials as a surrogate for ventricular tachycardia substrate in ARVC patients. Do you think similar attempt to map tissue heterogeneity on CT could be useful in patients with VF?
Yeah, it's a good idea. I cannot answer more. I think this is something we have to explore, but I have no specific experience on that. But it's a good idea.
By the way, just a comment, we published a paper on ARVC that combined ECGI with CT, with MRI. And the finding was that the electrical abnormalities preceded the structural abnormalities that could be detected. So that's something to keep in mind. Shiv Kumar has a question or a comment, I'll see. C. Buchans et al. Structurally abnormal myocardium underlies ventricular fibrillation. So for everyone, he's providing a reference for Buchans et al. That talks about the structural abnormality.
And also a nice review by Michel, Yoram. Yeah. Michel has written a very beautiful review on this whole subject recently, which we gave to the fellows. I put that in the chat. So great presentation, Michel.
Yeah, thanks, Shiv.
Thank you.
Those who want to see the references, they're in the chat box. Thomas Berry to everyone. Thanks for the great talk. Many patients have frequent PVCs on Holter recordings that are often considered benign. Do you have any thoughts on risk stratification for these patients based on their Holter recording alone, such as PVC coupling interval or dependence on heart rate?
Yeah, sorry. And risk stratification based on?
On Holter monitoring alone of PVCs.
Yeah, I think the Holter has a role to quantify the number and the pattern of ectopy. But this is excitability, the trigger, or the first bit. But the substrate is has to be quantified by ECGI or by MRI, CT scan, something else. We have two things.
Yeah.
But probably,
okay, thank you very much.
If there is a score one day, probably it should have to include depolarization, repolarization, and ectopic, pattern. And then we will have all the elements for arrhythmogenicity.
Thank you.
Okay. The next question is the following. Thanks for the nice presentation and a large body of work. Based on the cause of science cardiac death you observed, can you provide methods that would induce SCD in animal models reliably based on these observed mechanisms?
It's a good question. We don't have a good model. We have tried to induce with Ruben coronal some discrete lesion on the epicardium. It's not exactly the same type of electrograms. We have not resolved this issue.
Okay, Michel, we have one last question from David Peterson in Oxford. Thanks. Is there any clinical evidence for the beneficial action of modest hyperkalemia with beta blockers to minimize stress, sympathetic induced arrhythmia in LQT1-2 CBVT patients?
I don't know the answer.
Yeah.
Sorry.
Okay, there is no answer.
I have no answer.
Well, that's, you know, that's most of the time we don't have answers, so that's not surprising. So, Michel, thank you very much. I know you have to run to a meeting. Thank you very much for taking the time and introducing us to so much clinical data. It's been really a wonderful talk. Thank you. And thank you everyone for attending and participating with in the discussion. Ciao. And
Ciao. Thank you very much. Thank you. Bye-bye.